Hi, everybody. This is Kat Banakis. I am the manager for client engagement and support at Grenzenbach Lear and Associates Analytics. Welcome to the DonorScape webinar, Bridging Patient Data. I am joined today by my colleague, Andrea Fox. Andrea?
Yes. Hello, Kat.
Hello. Glad to have you.
Thank you so much for having me.
Today we're going to be looking at the University of Missouri Health System as a case study in building a bridge database system for the Grateful Patient Program. I chose to highlight Andrea's work and her team over at the University of Missouri because they built their bridge in record time with very little apparent pain, and they're already having really great results from a rather modest population. And we're going to be stopping the webinar at key points to answer any questions that you might have. To submit a question to us, you'll want to hover your mouse over the green bar at the top of the screen or the side of the screen, depending on how you have it, until you have a question mark or a conversation bubble. And then send that to host, which is my colleague, Catherine, who's sitting across the table from me, and she'll let us know when there are questions. If we can't get to any of your questions during the session, we'll be sending out a follow-up transcript with answers to any questions we don't get to, as well as a copy of today's PowerPoint and any other resource materials. So if you have questions at any point during the webinar, just as a matter of housekeeping, or are experiencing technical difficulties, please email my colleague Catherine at C as in cat, JULITZ@grenzglear.com, cjulitz@grenzglear.com, or you can call WebEx, our meeting provider, directly at 1-866-229-3239. That's 866-229-3239. So let's go ahead and get started here. Andrea, would you just give us an overview a little bit of the University of Missouri Health System, where you work, the team you've got, the population that you serve, everything like that?
Absolutely. Obviously, we're in the middle of Missouri, and our population being a university academic center as well as a healthcare provider. We are a safety net hospital, much like most of our other AMC peers. Our population is quite rural, other than Columbia, Missouri being university town of a population of about 100,000 people. We're finding that the concept of healthcare philanthropy is pretty new in this area. There don't seem to be a lot of people that understand that, you know, academic medical centers absolutely do need the help of our community to support what it is that we're doing. And right now, our health system exists as a school of medicine, a school of nursing, and a school of health professions. And then, of course, we have 7 different entities of healthcare and clinics out there as well. Ellis Fischel Cancer Center. We've got an orthopedic institute. We have university hospitals and clinics. We have a children's hospital, a women's center. We have a psychiatric center, and then, of course, a rehab center. So that being part of our delivery system, we are really trying to now focus on engaging our patients in philanthropy and to create this culture of philanthropy through annual fund and major gift, focus. The Grateful Patient Program just started August 1st of last year. I'm the first director of this program, and we haven't had a program before. But in the past, in 2009, our executive director of advancement, Laura Gaida, began the screening process through you guys. And so she had kind of started that, beginning of looking at patients as potential donors, but identifying the core way to set these up and how to work with patients has been something that I've been trying to stretch through this past year. So within our healthcare system, we do have 7 major gift officers, 2 Children's Miracle Network coordinators, myself as Grateful Patient Director, 1 Stewardship and Annual Fund Coordinator, 1 External Affairs Director, 1 External Affairs Coordinator, a gift processor, 3 admin assistants, 2 executive directors, and 1 associate vice chancellor. So that's kind of our system in a nutshell. Did I miss anything that you were interested in?
No, I think that's what we were going for. And you did mention that you're quite a safety net hospital in the region.
Yes, absolutely. We have 59.9 in the year 2011, 59.9 in charity care on a very small budget. So obviously, philanthropy, there's a huge need for it with revenue streams and reimbursement rates changing and things. So looking at this grateful patient idea and looking towards our community and patients that have had a good experience as potential donors is where it's at for us right now.
And when you started last August, what was what were all of the different places where data was being held on a daily basis that you were trying to bring together? What did you walk into?
Well, like I said, Laura Gaida and one of her assistants had compiled an Excel spreadsheet for me, and they had been collecting some names they thought through the screening process through DonorScape. 1 through 6 is what we look at as gift capacity, which 6 being a gift capacity of $10,000 or more. And they had been working on collecting those names and sending out some small surveys and just trying to see how people respond. Response rates were pretty good with those surveys. But we wanted to take that to the next level and actually start engaging our patients and finding ways to do such. And so one of the things that I found when I was in the morning coming in, looking at what patients had come through our inpatient hospitals, looking around, I started realizing I'm going to 4 different databases to gather the information that I was wanting to find. So we have our analyzer, IDX, which is our hospital admission information. I had access to some of that. I then went to Advanced, which is our past donor database system, past giving and biography on anyone who's ever given $1 to our entire MU system. And then, of course, I was going to DonorScape for the wealth screening information, taking all of that and putting it into one Excel master sheet. That was taking me hours every morning, and I thought there has to be an easier way to pull all this together that was not spending all this time.
Please, let there be an easier way.
Somebody help me here.
So this was the dream, that there would be one report every morning.
Absolutely. I thought, okay, this is a very far-fetched idea, but, if I talk to the right people, maybe somebody can help me at least pull some of this information to where I can just click on 1 or 2 things, and then boom, we have one report that shows that can stretch back for a month or the day prior or whatever I'm looking for, that I can pull that information and have it all in one sheet.
And then you went about trying to make reality out of this hope. And what did you end up doing to get started on that?
Well, obviously the biggest concern for everybody were the HIPAA and the compliance, solicitation of charitable gifts, and how that works with the patient database, making sure that we were being compliant in everything that we were going forward with. So first thing I did was contact our chief compliance officer and sat down with him and told him what it was that we were doing. And we had already had some things in place, but I wanted to expand on that at whatever level he was willing to let us find, whatever he found it was compliant within the terms of HIPAA. And so we did have a policy change that was written by the CCO and signed by our CEO, and that includes information, such as the patient demographics, their name, their spouse's name, address, their date of birth and gender. If they're privacy flagged, that would be flagged so that we wouldn't bother them. Insurance information, dates of treatment by location. So if I knew, obviously we have several different locations, I would need to know if I wanted to visit where they were located, because I do personal visits on occasion. Needed to know if they were inpatient or outpatient, obviously again for visits, patient satisfaction, some of these other things that we wanted to make sure that we were compliant in all of this. But we did not have access to any medical records, obviously, no physician information. I don't have access to any of that. And then we started realizing I had an officer approach me and say that, she was having a hard time when she was talking to some of the patients feeling free to discuss things out in the open in some of our office settings. So we felt like it would be safe, a good idea to have all of our officers sign the confidentiality statements that any volunteer or hospital worker would sign to make sure they're not discussing anything they hear over the phone. And that made everybody feel a lot more comfortable knowing that, okay, we're all in agreement here, we're compliant, and those were turned into our compliance office as well. So took care of the safety part first and make sure that we are not violating any rules.
Which absolutely makes sense, both to get the formal compliance so that everyone's on board, but also so that everyone who's involved in it has a sense of security and what is appropriate, and that you're really honoring your patient's privacy.
Absolutely.
And it was a fairly elaborate team that you ended up having to pull together on this from all different parts of the university and hospital system.
It really was.
Can you walk us through the different folks here?
Sure. Obviously, as I mentioned, all of those different databases have the folks that were in charge of putting those together, and I really didn't know at first, okay, who do I go to? And I just made sure I went to the right person that I knew had the knowledge and insight and the power, I guess you could say, to get this stuff done, the ability. And with our IDX hospital side of things, we obviously worked with the CCO and the compliance, and then Deanna DePriest is our programmer or specialist for the IT applications for our healthcare side of things. So she's where we came from first to pull together just the basic patient information that came through on a daily basis. Then we have our advanced IT staff, which Advance, again, is our donor base for any past gifts that have been made. Tom Boren is the Director of Development Advancement Services, and Hong-Ying James was our Principal Programmer, and Rich Greenup is a programmer who worked with us as well. And then our research team, who knew a whole lot about GGNA and kind of could pull all of these together. Director of Development Research is Pam Smith, Senior Research Analyst Heidi Harmelink, and our Research Analyst David Moore. All of those played a key role. And then, of course, GGNA, you folks up there, Kat, you, and Paul were integral. I mean, this could not come together at all if it weren't for each of those individuals I named helping out on some level or another.
So it sounds like it was just both the content advancement and also IT for all of these different sources and databases.
Yes, and it was kind of funny because one side might not have understood what, a hospital wouldn't understand the development component. So having them understand what it is that I was looking for and having IT get what hospital had and everybody connecting all of those links, that's where the whole bridge part comes in. And it was a little confusing at first as to how to get everybody to understand what it is that I was after. But we had several meetings in the first couple of months and it took, there was one point that it all came together. I think you'll hit on in a minute. Yeah,
let's actually jump right to that. So okay. When it all came together was when the Sharpie came out.
It was the funniest thing because I think that one of our meetings that we had a big table, and here I was talking with my hands, showing, okay, if we pull it from here, and this is what I want. Everybody was looking at me like I have no idea what you're talking about. So I just got out my Sharpie, and here's like on a sketch piece of paper, this at the bottom you can see the grateful patient data file. That's our Excel sheet. We were churning that within our, here in my end of my office. Number one, up in the top left corner, pulling information from the hospital, adding it to the file. Then I would go to DonorScape and pull the wealth information from there, which IDX had already fed DonorScape, obviously. Pull information and manually enter it into Excel from DonorScape. Then I'd go to Advance and run individual prospects, individual patients through Advance to see if they had made gifts in the past. And then I would feed that onto our Excel sheet as well. So that process, you could see, okay, this is what we were doing at the time, and it was not very efficient for what we were doing. So then I drew them a drawing, which I think is the next slide, that shows what I was after. So what I was after is at that bottom, the Grateful Patient Program Full Information Report. So again, it starts at the top left. Hospital feeds DonorScape as it had already done. That portion never really changed. but how we fed it did. We'll explain that in a bit. And then from DonorScape, it would bounce. I would like it to grab the information from Advance, and if the patient matches to Advance, bounce it back up to DonorScape, to where I can just go in and daily pull from DonorScape and get all this information thrown into one sheet. So that was kind of the idea, as you called it, the dessert. Just having a one-step process, but I am not an IT person. So for me to go in and try to explain this to everybody was pretty funny. So it took the brains behind the IT and the techie side of things to get that done, and thanks for my wonderful team for being able to do that.
And so once all the different component teams understood what part you wanted in the final report, then the coding and the technology could happen, but it really took understanding, well, what is it that you want from my part of it?
I think so, yeah. What do you want, Andrea? What is it that you're pulling us all together for?
We want to do this for you. Just tell us what you need.
Well, that was the surprising part of it. It's like, you know, anybody can come up with a project to do, but to get people kind of excited about doing something new, I was a little worried about. But, you know, everybody was so on board, and they thought, well, this will be interesting to see if we can create this for you. And I mean to tell you, I have had the best luck with this group of people, and they just all have been working together to create something that's fantastic. So I'm very appreciative to them.
That's great. And the actual coding is not that different from your initial Sharpie drawing. So
a little neater, maybe.
Well, you know, maybe. But
yeah.
From what I understand, the way it actually ended up being coded is that you upload your records at the end of the workday. The hospital registration files go in CSV format to a secure FTP, a file transfer point, which is, it's sort of like a hallway where files can be dropped off and picked up in a secure way. So the hospital registration intake goes to the secure FTP. DonorScape picks it up later that night and runs the hospital file through DonorScape. The next morning, early, Advance, your donor management system, picks up the DonorScape export file and then parses it into 3 categories. So the records that come from DonorScape that were the previous day admits to the hospital are either matched records in advance, so they're known prospects, in which case it updates in advance their alternate ID, or they are unmatched, and then those that are unmatched, if they have a gift capacity rating of 1 through 6, they are given an advance ID and entered into advance. If they're unmatched but given a DonorScape rating of 7 through 9, 7 and 8 being fairly modest, 9 being unable to rate, they just are left alone. But then those that have, and this is all happening all at the same time, very early in the morning, those that are either matched in advance or a DonorScape rating 1 through 6 and then entered into advance, then had the advance ID and available advance information field updated into the DonorScape account, so that when you pull your final report, when you come in, it is capturing advance matches and those that have a DonorScape rating 1 to 6.
Exactly.
Which I think is incredibly cool. And let's actually look at what your report looks like when you pull it in the morning.
Yeah, this is really the exciting part, and this is where our research team, Pam Smith and Heidi and David, they really helped with this initial mapping. So anyone that uses GGNA DonorScape is familiar with this full report of the prospect details. And what we did, I think it's the second page there. Okay, yeah, see the data source on that 4th page. IDX, that's from our hospital, is coded in red. blue is our advanced system, and then green is GG&A. And then we do have some fields that are going to be added down the road. So did you want to go through this so we can talk about each of the different components?
Yeah, let's just look a little bit about how it all comes together. So you're pulling the name and the date of birth, and anything else in red is the hospital data.
Yeah, and I will say, I think that the team would agree, this was probably the most complicated part of the whole process, is finding out, okay, so some of your data fields are solid, are in there, we're not changing them. And then it's the constituent codes that are the client-defined fields that we can add and put whatever we want on there. So, 1 through 20, those are ones that you guys allow people to add whatever it is they're looking for. So we thought, well, there are a lot of fields. We don't want to use up just the constituent codes. So maybe we can kind of re-identify within our own realm what those are going to be, because I think a lot of this report reflected that they were alumni and not patients. So that was kind of a fun way to do this mapping, and I had a lot of help from our research team putting this together, and it was pretty tricky. I will say this was the hardest part. But once we had this all lined up, go ahead.
The titles are hard-coded, right? Like graduation date and campus site. Those are the non-negotiable headers.
Exactly.
But I love how you were creative in the translation. So
yeah. I like graduation date, so it's kind of morbid. But under school, because this is not a school, it's hospitals. Graduation date, well, that if they died while they were in the hospital, we would obviously want to know that information. So graduation from life, I figured that's a good death date to put, graduation date.
Yes, and which college campus they're on, or the facility.
Yeah, room and bed, wherever they're located, absolutely. So we were kind of creative in that school area, but we were able to utilize those hard-coded fields rather than use our client identified ones. So starting up at the prospect, obviously this is basic information that mostly comes, this is what I used to pull. Everything in green is what I used to receive, and I thought, well, let's just try to fill in all these fields so I can have all this information at once. So in green, that's what I was pulling before. And then under home address, obviously, that's information that would come from hospital and feed into you guys, GG&A. And then the gift information, this was a really exciting portion to pull in. So down there in the blue on that first page, total giving dollars. I mean, can you imagine you're wanting to see, you're pulling up these patients and you're like, wow, I can look at one sheet and see, has this person ever given to us? If so, how much? What are the total numbers of gifts that they've given? What's their largest gift amount and the largest gift date? And then, of course, their most recent gift amount. One of the things that I'm going to tweak, and I've talked to Pam about this, is adding possibly adding, have they ever given to our health system before? And if so, how much? So adding that field as well to identify, yes, there has been a health system. It might not say they've given to the cancer center, they might have given to children's, but it could say, yes, they've given to health system and they've given X amount of dollars to health system in general. So that's one of the things I'd like to add down the road. And then obviously, if they are already matched to Advance, and Advance is feeding back information, the spouse, first name, ID, that their spouse's ID number in our Advance system, and business information. That's been very handy too. I was kind of surprised. I didn't think, when going into it, I just thought, oh yeah, let's just put those fields in there. And I didn't realize how important that truly is. It's just another element that we can go, oh, their job titles now listed. When I pull these spreadsheets and download the GG&A portion, the DonorScape portion into an Excel sheet, I can now see, hey, this is the president of a company. This is a director of something. I really want to hone in on some of these job titles, like, oh, okay, CEO of what? And we can dig a little more that way. Seasonal address comes from our Advanced system. Some people have 2 homes, and that would be their second home located. And then obviously we discussed the information in the red that we entered from school. That came from our hospital side. Miscellaneous, that constituent code 3, that comes from our Advanced system as well. That lets us know if they have graduated from our institution somewhere, and lets us know what health, environment, sciences, arts and sciences, business, indicates where they have been assigned, or where they've graduated from, rather. So that assigned solicitor, obviously we have gift officers all across our campus. So if this prospect is already assigned to a different gift officer, then that's obviously good information to know too, so that we're not talking to somebody that already has the rights to them. Going down into the client-defined fields, confidential, this one's not used very often. I mean, in fact, I don't think I've ever seen anybody this is just a yes or no answer. So what comes in is client-defined field is either a Y or an N. If it's a Y, that means it's confidential, leave them alone, don't do anything. If it's an N, they have not put in a confidential flag. Inpatient and outpatient is I or an O, pretty simple. Discharge disposition. This was a bit of information I thought would be important as well. If a patient has gone on to a rehab clinic or has moved on to a nursing home or skilled nursing facility, we obviously don't want to try to visit them or talk to them at that time, because it's not a medically appropriate time. I don't know what their medical condition is, but I would just see that they were either released to go home or take care of themselves, that sort of thing. Client-defined field 4, I failed to mention that when I talked about the compliance letter. We gained permission to grab their patient satisfaction scores once they've left the hospital. Everyone receives a survey about their experience, and they did not see a problem at all. If the patient is self-identified on those surveys, that is not a HIPAA violation for us to say, hey, they rated our institution at 92%. Now, how perfect to see. Here was a patient. They have this, a gift capacity of 4. They had a great experience, 92% score. Great. This is a perfect combination of a potential grateful patient. So I really like that component. We don't have it coming in yet. That's on the down the road list. We're working with HR to try to get that component. That's a whole different person feeding into you guys.
Sure.
But that's pretty exciting right there. The client field 5 was the guarantor. If not our patient, if somebody else is the guarantor. This is nice for when children come through. If it says somebody else's name on that, it makes me look at that date of birth a little more closely. We obviously don't want to send mailings to children. That would be weird. And then client field 6, patient relationship, so if it's a mother or father, a spouse, that kind of thing. Advance ID number is added on there, which makes it very easy to go back and search Advance. If we find out they are donors, I can get back in Advance if I desire to find out a little bit about what their past giving was to, and just click that number in there.
Just to clarify on that, Andrea, when the patient information is coming in, if they're not already in your donor management system for the university, if it's a patient with a gift capacity rating 1 through 6, they're given an Advance ID, right? And they're
exactly.
So then they become part of the donor management system and get an Advance ID in this field.
Right, and that is so wonderful. I mean, that was something we toyed around with for a little while. I know Tom was a little like, oh, I don't know if we want to add people that we haven't had no relationship with and know but that they haven't given money to take up too much space in our management system there. But he was very gracious in allowing us to go ahead and do this, because where that came from is a lot of our officers, part of being in development is tracking the number of contacts you've had and substance visits and such. Well, if you can't report who you've visited with, if you visit a patient that I've referred, if you can't go into your data management system and report that, then what's the point of them meeting with them? So. Sure. We needed to have these patients added. Now, they're not added as patients. No one knows they're patients that are being added. So, our whole our whole development system can get in the advanced database. So they're entered as a friend. We have many different friends from the community and such. So sure. They are ID'd as a friend, and then we can pull it, our team can pull it, information if I want just the patients that have been uploaded. They have their own way of doing that no one else knows that, hey, that person was entered as a friend, but they were a patient. So we want to keep that very private. Yeah, and the officers really appreciate that. They're like, okay, good. So if I actually go talk to this person, they're already in Advance. I don't have to worry about, you know, making a new contact report or a new entity in our management system. So, and then the geotype, that's just kind of the county, which that's kind of, it's not as important in our area, but most of we do service 25 counties in mid-Missouri, but
huge geography.
Yeah, it really is. We've got this, other than Kansas City and St. Louis, just to the east and west of us, 2 hours each way, we cover a good majority of the state of Missouri. Number 9 is really, I was so glad to get this one filled in. I didn't know that we would be able to do this, but Deanna somehow figured out how to put in there the number of visits they've had. So that is a key indicator towards affinity. Obviously, if someone has been to your institution over and over, they're going to feel more like they're a little more invested in who we are, feel more like they're more part of our family. If it's one visit, you might not think, okay, they just had a checkup or whatever. I don't know what they had, but it's just a one visit. And if they've been in and over again, they've obviously had some sort of affinity to it. So I like looking at that number as well. Email is something new we've added. I'm hoping down the road to have a lot of emails collected. We don't collect them from all of our patients upon registration, but I think they're leaning towards doing that a little more. That way we can maybe do email blasts to our past patients and do solicitations that way, or appeals. And then birth year was something that I added on top of birth date, because sometimes those fields that are hard entered, you would know more about this, Kat. I think you and I actually worked on that together. Pulling, I sometimes wonder if we want to do a planned giving mailing, which is 55 and older, just to pull a list off of based on birth date or birth year. That sure makes it easier right there.
Sure.
19, caregiver recognition. So again, if a patient is telling one of us, I just love Dr. Jones, he was the best thing ever, we can enter that information on there and kind of know who they are recognizing. And this is information they share with us, so there's no HIPAA violation at all. They are just saying, I want to recognize so-and-so, and that's what that field would be put in there. And then 20 is essential, and that was something we had from the beginning, is the date of the last admission, so that I know, okay, so this person just was admitted 2 weeks ago. We want to give them some time to get home and get situated before we send out any mailings or try to contact them. So this has just been wonderful, the amount of information that we are able to pull on one sheet this way, and saves me a lot of time every time I want to do a mailing. I can just download it from you guys and have all the information I want right there.
That is so fantastic. And I'm just so impressed that you're able to pull that all together. And it's been an evolving process, right? Because you knew some of the fields, and then adding in email, adding in birth year, different things you've added on over time.
Right. We had just kind of the initial, and then we kind of just add. And I would always kind of feel bad to contact anybody again and go, hey guys, can we didn't think about this. And the first thing, we didn't think about gender until just about 2 months ago. And then when we were wanting to do mailings with salutations, some of the names. Yeah, you don't want to say Mr. Terry when it's Mrs. Terry Jones, Sure. So that was something we'd have to go dig around through hospital information and find out what their gender was. But Deanna, just no problem. I'll have it on the next batch. It'll be sent out through the next batch. And just having these team players kind of willing to go, yeah, we can tweak that, no big deal. And I think Paul Mateo there was probably sick to death of me emailing him going, okay, Paul, how does this work? Because like I said, I'm not a techie person in the very least. I'm tech challenged, but I have some good buddies that know what they're doing with the technology side of things. So
it's been such a fun project. So what are sort of your next things to get through, because it is a living and evolving project?
It is definitely evolving, and one of the things we recognized recently, as well as gender that I just mentioned, was one of our officers actually had a friend who, or somebody that she knew that was a trauma patient, and she said, I know this person. And I went into GGNA and I said, no, they didn't come through. And she says, well, I know she should definitely be a 1 through 6. I know this person. And I looked again and I said, no, I don't see that name in here anywhere as one of our screened patients. And we started going, well, I wonder what that's about. So I contacted Deanna, and she does a T-1. So today -1 when she's uploading all of the patient base. So what Deanna figured, she said, okay, let's do a T-2 because trauma patients, surprisingly, they are given an ID number when they come into the hospital that has already been processed. So, you know, if a trauma occurs, these people might not have identification. We might not know who they are when they first come in. So they are pre-registered, if you will, and a number is thrown on them as a patient number. And then when their information starts trickling in the next day or a day after, that's added. So now Deanna, just for the trauma patients, does a T-2. I don't know if they're trauma patients or if they're something else, but it comes in the day, 2 days later to me. So that was really neat because, you know, traumas, we're the only level 1 trauma hospital in mid-Missouri. So that's you know, a good opportunity for prospects. You know, you don't choose where you're going. Yeah. So that was something we've tweaked. And then one of the problems I'm running into now is kind of deduping the repeat admissions. So if I want to send a letter to every patient that's come in this past month, I want to be able to make sure that they were not sent something the month prior. And so one way to do that, obviously, is to pull the list from our advanced management system so they can see, oh, wait, these people have already received this appeal. You want to exclude them from your next one. So rather than just coming off of the information that comes from DonorScape. Does that make sense? We were, you know, pulling DonorScape, and I don't want to send somebody the same thing twice in 2 different months. So that's something we're working on with with our advanced research team and IT team as well to make sure that we're not duplicating those appeals. It gets kind of a little complicated, obviously, trying to just keep track and making sure you've got your ducks in a row there.
Yeah, especially when you're dealing with thousands and thousands of people for mailing lists, of keeping track how you're categorizing them and everything like that.
Absolutely, and that was one of the things that we found. You know, on this slide I mentioned that we added our outpatients. Now everything that we did from August on has only been inpatients. So we might only receive, you know, on average, I think our average was about 70 patients a month that screened 1 through 6 that we might be soliciting that way. And whenever we were a little worried because we heard that our outpatient services were about 6 times the number of patients, and sure enough, it was. We've got that many more patients now that we added the outpatient list in February, and that's been really fun and kind of actually overwhelming because I'm like, oh my gosh, what do I do with all these people? But it's been pretty neat what we've done.
So many grateful prospects. It's an embarrassment of riches.
Yeah, now how to meet with them and get some money coming in, right? September, obviously, go ahead.
No, I was going to say, but you actually have started attending to that in sort of a mass setting. And if we go back through this, you got there in August, you started thinking about it in September, it launched in December, and then take us through what happened just so far in 2012.
Okay. Again, you know, added the outpatients in February, which, whoa, we had so many people coming through, and I've really kind of started the assigning process, if you will. Like if I find a prospect that I think is just a key person that one of our officers should meet with, I kind of hand them one of these prospect detail pages and say, okay, this is what I know. This is a lot of information here on one sheet. Go for it. You know, go see if you can set up a coffee meeting or something. So that was just a normal kind of handoff that way. But then we updated our mailing list with, for example, if we used our Ellis Fischel Cancer Center, any patients that had ever come through there, we were able to update our mailing list and enhance that so everybody's receiving our publications. We have held, I mentioned Ellis Fischel because we are expanding that institution and growing. We've got a new patient tower going up right now, and that's something that we're trying to raise funds for. So we've put together patient patient information forums, if you will. So we invited them to come attend these patient forums, and we have some snacks for them, and we have our key cancer doctor come in and speak to everybody. We have the interim director for our facility come in and talk about the changes that are happening with our facilities. And then I talk about patient programs, volunteer opportunities, and obviously giving potential opportunities, naming opportunities as well. And those have been, the attendance hasn't been huge, but those who have shown up, and obviously these are people who are 1 through 6 that are showing up, those who have attended these forums the last 3 months have been great prospects. We've actually, one of them has joined our advisory board for our cancer center. We've got one that's signing up to be a volunteer. We're just engaging, and I'm finding that people really respond to opportunities of engagement. They want to be involved, just talking to them first and getting them, building that relationship, and this has been a great way to do that. So from there, we want to kind of make it bigger and take our top, I don't know how many yet, I'm still kind of planning this portion, but to hold a health system breakfast, if you will, and have our vice chancellor attend and talk about what we're doing as a system, have our deans come in and talk about our 3 different schools. Just make it a really nice breakfast and invite only those key top-rated patients to attend this breakfast. So that's on my agenda for this next fiscal year, to accomplish that, and then have our officers there as well to, obviously start building some relationships with these attendees. So it's been really fun. I think that you say it went fast, 4 months to put this together, and when you're in the thick of it, you're like, oh, we have to have another meeting. We have to have another meeting. So those 4 months, we had a lot of meetings, a lot of emails, a lot of discussions, and I felt like, oh, this is taking so long. But looking back, I guess 4 months isn't so bad.
Not at all. Well, Andrea, I just want to thank you so much for our time together today and for sharing your story. You had said before that you would be open to people contacting you for follow-up. So
absolutely.
Here is Andrea's contact information here. Paul and I here at GGNA are happy, of course, to discuss the technical side of bringing this together for anybody who might be interested in creating a bridge in-house. And as I said at the beginning, we'll be sending a follow-up of today's presentation, as well as any questions that you think of and want to submit either to Andrea or I later today. I'm at support@donorscape.com or kvanakis@grensclear.com, and Andrea is foxand@health.missouri.edu. So if anything comes to you, please do let us know. Andrea, thank you so much for your generosity of story and spirit, and congratulations to your whole team for building this exciting new process, and we're just really hopeful for what it's going to bring in grateful patients in the years ahead.
Well, thank you so much. And it's one of the things you had asked previously what the key component was, and you hit the nail on the head just now, and it's the team. I had a fantastic team. I found the right people who were willing to work with me and who knew what they were doing, and none of this would have happened if it weren't for each of those folks that I mentioned. And I think that's, if anybody's wanting to build this bridge in their own system, you definitely have to find the right people who are the ones that have that authority to put these in place. So I just, I recommend going to the right people and just kind of getting them excited about what it is that you're trying to do. So I'm very thankful.
And it is exciting work. I mean, creating healthcare for people it's great work. It really is.
That's why we're here.
Thanks, Andrea.
That's right. Thank you so much.
Have a great day, everybody.
Bye-bye.